Welcome, everyone. I'm JT Vannah, your host today from Neuroelectrics. Thanks for joining us for our final panel discussion of 2024, Suicide Prevention by Adapting Brain Circuitry. We'll address one of the most pressing public health challenges today, with suicide being the 10th leading cause of death in the US, taking over 48,000 lives annually. The psychiatric industry faces a critical moment. Traditional treatments have proven inadequate, with millions of individuals suffering from mental health disorders, often receiving delayed or ineffective care. This panel will explore how advanced neurotechnology, like non-invasive brain stimulation, can target and rewire dysfunctional brain circuits, offering new hope for those at risk. By adapting brain circuitry, we can aim to create groundbreaking interventions that could transform the landscape of suicide prevention and mental health treatment. We're thrilled to have you along to learn about these research advances and connect with thought leaders in the field. This program is the fourth of our quarterly panel series in celebration of Neuroelectrics' 10th year in Boston, Massachusetts, focusing on themes surrounding mental health challenges. Today, our topic is suicide prevention by adapting brain circuitry. If you happen to have missed a prior quarterly discussion, please reach out and we'd be happy to send you information on one of these discussions. Without further ado, let's introduce our esteemed speakers for this event in the order that they will appear. First up, Dr. Joan Camprodon is a leading figure in the field of neuropsychiatry, recognized for his innovative research at the intersection of neuroscience, psychiatry, and neurotechnology. As a neuropsychiatric researcher, Joan's work focuses on understanding the brain circuitry and developing cutting-edge therapeutic interventions for mental health disorders. His contributions to the study of brain stimulation, neuroimaging, and translational neuroscience are shaping the future of personalized mental health treatment. With a passion for improving clinical outcomes, Joan's research is paving the way for new insights into conditions such as depression, anxiety, and other neuropsychiatric disorders, making him a key figure in modern neuropsychiatric research. Next, we introduce Dr. Giulio Ruffini, a visionary and pioneer in the fields of neuroscience and neurotechnology. As the Chief Technology Officer and co-founder of Neuroelectrics, Giulio has been instrumental in developing groundbreaking solutions that are revolutionizing brain health. His leadership extends as CEO at StarLab, where his expertise continues to push the boundaries of neuroscience research. A respected European Research Council investigator, Giulio's work embodies a commitment to scientific excellence and innovation, driving forward the future of brain health and technology. His passion for blending science with real-world impact makes him a key figure in advancing non-invasive brain stimulation and personalized therapies for neurological disorders. Finally, Dr. Francesca Castaldo holds a PhD in theoretical and computational neuroscience from the University College London, with a background in robotic engineering and biomedical engineering. Currently, she serves as the research program manager and senior scientist in the brain modeling department at Neuroelectrics. Her expertise spans the in silico modeling of the brain across different scales and neuroimaging modalities, alongside a focus on research management and strategic grant development to advance neurotechnological solutions for mental health disorders. Thanks all for being with us today, both to our speakers and viewers. Following the presentation, we will engage in a panel discussion where our speakers will provide insights and we'll address questions that are raised. So let's get started. Joan, whenever you're ready, the floor is yours.
Thank you, JT, and thanks everyone for being here, and to the Neurotech team for inviting me to join. It seems to be quite an exciting panel. So I was asked to give a brief introduction to a framework to think about the challenges we have in psychiatry, neuropsychiatry, and public health, to think about prevention and for suicide and mood disorders broadly, but I think beyond that, and how we can not only think about that at a public health level, but also in terms of treatment development. These are my disclosures. And as sobering as it is, I think it's important to start with the facts. And the facts are that we are indeed in a suicide epidemic that's affecting us worldwide. What you're seeing here, it's the mortality rate for a number of medical conditions through the last, give or take, 100 years. And what you see is that medicine has been making progress, quite a lot of progress, and mortality for gastritis, tuberculosis, pneumonia, flu has really been going down, mostly due to the developments, discoveries of new treatments, understanding the mechanisms of these diseases, developing healthcare delivery programs and prevention programs that have been able to move the dial. But that has not been the case for suicide, right? You see, for suicide, in fact, we are kind of stuck. Not only we're stuck, but things are getting worse. So you look at the last 20 years, or the 20 years between 1999 and 2019, there was an increase of 33% in suicide. And note that these numbers end in 2019, and something quite significant happened right after. We know that in the context of the COVID pandemic, suicide rates increased further up. And it did so particularly for younger populations, so children, adolescents. So we're kind of stuck. And this is not because this is a neglected problem, or because there's no funding for research, or because there's no funding for clinical programs. There's actually a lot of interest, there's a lot of funding, but it's a very difficult problem. And we're not quite making progress. So when you start at that level, I think it's important to step back and just question the very principles, the very definitions of the problems you're trying to address. So what is suicide from a clinical perspective? Historically, we thought of suicide as a symptom, right? A symptom that is in the list of, for example, the symptoms that define what major depression is, what major depressive episode is. But it's truly suicide a symptom. And I would argue that it's so complex and so heterogeneous that it's more than just a symptom like insomnia or decreased appetite or problems with concentration. One could argue whether it's a dimension in the way that the NIMH is thinking about the research domain criteria of dimensions of positive affect, negative affect, cognitive functions, and so on. But again, there's too much heterogeneity for it to just be a dimension. And if you step back and think about what a suicide is, then it's actually a definition of signs and symptoms of subjective complaint and objective observations that are heterogeneous and that are described really at the phenomenological level. And that in medicine is a clinical syndrome, right? A clinical syndrome, again, is a constellation of phenomenological features, clinical features that either physicians or clinicians can identify objectively or patients will report subjectively. And if you think about suicide as a clinical syndrome, that's not just like an academic switch that allows you to kind of redefine pathology, how we classify diseases, but it can actually offer at least the option for a different approach. Right? If you think of suicide as a syndrome, you can do what in neuropsychiatry we do with syndrome, which is you can dissect it into its core dimensions of affect, cognition, behavior, and autonomic function. So get into those dimensions. So you think, what are the critical dimensions of suicidal patients? Well, suicidal patients have problems with self-perception, right? Suicidal patients violate one of the more critical principles of biology of self-preservation. They have problems with making decisions. They have problems with cognitive control or impulsivity. They have problems with deficits of positive emotions, excess of negative emotions. Again, like all syndromes, not all patients have all of this, but all patients have some. And if you go from the syndrome to this dimension, then you can do something that is relevant to treatment development, which is then think, okay, what are the circuits that process this dimension? So for self-perception, we know that the full mode network is particularly relevant to in terms of its computation. Decision making, you have the executive control network. Cognitive control, you have the executive control network. There's other behavior inhibition networks, and so on. Limbic and reward, limbic and fear networks. So again, if you think about it as a syndrome, you can then dissect it clinically into its core dimensions, and then you can start making formulations at the circuit level of both suicidal patients individually for clinicians, but also in terms of treatment development, you can start framing the program at the problem at the circuit level. This is a theoretical model that needs to be tested empirically, but there's something that is very empirical, and it is that we know from lots of different studies looking at post-mortem studies at FDG PET, looking at metabolic activity, MRIs, etc., that the anterior cingulate cortex, or the ACC, is a critical node in suicide that biologically has a signal that explains the clinical severity. So again, in post-mortem studies, we know that those areas have different number of cells, different histological or site architectonical compositions, different types of arborization. Metabolically, we know that metabolic activity of the ACC is lower. These areas are thinner structurally. So there's something in the ACC that is relevant as attested empirically by research. And interestingly enough, the ACC is a critical node of many of the circuits. Not only that, but it's a critical node that integrates function across this circuit. So with this framework in mind, we went on to run a study where we tried to develop biomarkers around the anterior cingulate. We know that electroconvulsive therapy, ECT, is one of the most effective treatments we have in psychiatry. And we know what was one of the few treatments that have intrinsic anti-suicidal properties, right? We do have treatments for suicide. We just don't know how they work or for whom they will work. But we know that it works for suicide. So we try to frame ECT not just as a therapy, but in this case as a probe that will help us identify biomarkers. So if we know that the anterior cingulate is particularly relevant, the question was, one, are there any features about the functional connectivity of the anterior cingulate, so the functional dynamics of the circuitry around the anterior cingulate before ECT that will help us predict who will get well and who will not get well in terms of suicide risk? So these are predictor biomarkers. And the second question was, are there any features about this connectivity that throughout the course of treatment change, and in that biological change explain the clinical change of the reductions in suicide rates? And that becomes a response biomarker. So we identified this node in the parietal cortex, in the inferior parietal lobule, that indeed had a pattern of connectivity before ECT that predicted the change in clinical severity. And what we saw, in the y-axis, this is the clinical change. This is 0. The further down you go, the better off patients are. And in the x-axis, you have this is 0. So basically, the stronger the anti-correlations, the tighter the connectivity before treatment, the better off patients will be after treatment. But then the most critical question for treatment development is not so much the predictions for response. This is a signature that can help us make decisions in the clinic. But if we want a signature that can help us develop novel therapies, we need the response biomarker or the mechanism of action. And we identify also inferior parietal lobule on the right hemisphere that had a pattern of connectivity with ACC that actually, in this case, longitudinally change and explain the clinical benefit. So again, let's go to the graph. The y-axis is the same. 0 is here, and the further down you go, the better off you do with treatment, so the more improvement you have. In the x-axis now, we don't have the baseline connectivity, we have the change in connectivity, and this is the 0. So basically, the more ECT could move the connectivity between these two nodes towards the positive, the better off patients will be. So we have a predictor biomarker and a response biomarker, and as you can see here, they overlap quite a bit. Now, the mechanism of action, the response biomarker, is the particularly relevant to think about this problem and to think about developing therapies for suicide patients from a bottom-up perspective, informed by biomarkers. If indeed moving the connectivity between the ACC and this parietal lobule towards the positive seems to be correlated with improvement of suicide, could we use a more focal therapy, a more personalized and precise therapy like TMS instead of ECT? To stimulate this parietal lobule, engage the connectivity in this direction? So first question, could we move the biology in the same direction? And if we do that, second question, could we then see the same types of clinical effects, meaning reduction of suicide rates? So we ran a study after that one where we tried to ask these two questions. Can we engage the biology? Can we get benefit from decreasing suicide rates? So we brought in patients who had either major depressive disorder or borderline personality disorder, and they were moderately to severe suicidal, so STD, suicidal thoughts and behaviors. And the 3 visits, the first one, they come in, we scan their brains, we assess them clinically, and then 2 days later, they come and we do an individualized MRI-guided stimulation with an accelerated protocol. It's a single day of treatment. But for each one of these patients, we identify this cluster in the parietal lobule that has this pattern of connectivity with the anterior cingulate. That's the stimulation target for every patient, but it's different for every patient because it's individualized to the unique anatomy, to the unique functional patterns of connectivity. Once we find this unique pattern of connectivity, we apply 10 sessions of stimulation in a single day, similar to the same protocol that has been already approved for depression. By stimulating the dorsal prefrontal cortex. So our target here is not to improve depression, it's to improve suicide rates. And after this 1 day of treatment, we brought them back, we scanned their brains again, and then we assessed them clinically. And what we observed clinically is that there was a decrease in suicide ideation of 48% that was significant after a single day of treatment. Now, bear in mind, as I mentioned, this is very important. This is an open label study with 10 patients. So there's so much you can generalize from this, which is not too much. But I think the main point here is to see that there's a signal that you can actually implement this biomarker-driven model for treatment development. So we did see these very relevant change in suicide rate after, again, a single day of treatment. And then we also saw some change in the intensity of the suicide ideation that was trending but didn't quite reach significance. So again, this is the clinical effect, but we also wanted to have a sense of the biological effect. Again, the hypothesis here is that we will be able to stimulate the parietal cortex and change the connectivity towards the positive with the anterior cingulate. So this is the anterior cingulate. This is the medial look of the brain. This is the lateral look view of the brain. And you can see by these yellow colors here that we are moving the connectivity towards the positive. Now, this is looking at every voxel in the brain. This is looking at specific parcels in the brain. But again, we have these these warm colors mean positive changes. The blue and green colors mean negative changes. So again, we're seeing a change with an effect size of cohency of 0.71. So a mid-size moving towards a large effect size, but I would say within the mid-size effect. So again, these are very promising results. We still have to, with this evidence, move on to doing a randomized control trial. We are doing a randomized control trial. But again, for me, this is a model for how we can reformulate what suicide is, and based on that, do what we do in other areas of medicine, which is develop treatments based on our capacity to identify biomarkers. So in psychiatry, we've been very lucky. Serendipity has been our friend. We've developed quite a good number of treatments, but without really much of an understanding of the mechanisms of the problems we're trying to solve, or much of an understanding of how our treatments work. But I would say that, well, as a clinician, I welcome these treatments, even if we don't understand their mechanisms. We've been stuck for 20 plus years in our capacity to develop novel treatments. And part of this is because we've been stuck in our capacity to do this, to do treatment development informed by biomarkers. So in neuromodulation, what does that entail? Well, we know in neuromodulation, the biological level of analysis is circuit, right? So if we are interested in circuits, there's three variables we need to understand. We need to understand the anatomy of the circuits, the physiology of the circuits, and their behavioral computations. So we need to have that research that will help us understand disease mechanisms at this level by looking at these three levels of analysis. Now, understanding pathophysiology is not enough. We need to, it's related to, but different from biomarker discovery, right? Now, when we talk about biomarkers, sometimes it's a bit of confusion, and part of it is like, what is a biomarker really? And it's because there are different types of biomarkers. You have disease biomarkers. These are signatures that can help you. These are who has a disease or who doesn't have a disease, who has disease A versus disease. Then we have severity biomarkers, which will tell us, how severe of a condition do you have. Then we have prognostic or predictive biomarkers. These are signatures that tell you something now about what will happen in the future. Will you respond to treatment A or not? Will you get side effects or not? These are signatures, biomarkers that help you make decisions in the clinic. But for treatment development, what's really important are the response biomarkers. These are, as I showed earlier, dynamic signatures that when they change, they carry with them the variance of the clinical severity, that explain the clinical severity. And once we have response biomarkers, they are less helpful in helping us make decisions in the clinic, but they are critical for us to be able to develop treatment. And what I just showed you earlier is an example of that, of how we first focused on developing these biomarkers. And once we had that, then we were able to develop, or think about what are the optimal ways of engaging the maladaptive biology to improve clinical outcomes. And again, this is how we would do it for regular neuromodulation, but we all know that that may not be enough, that we are dealing with the brain, which is a very dynamic and complex and very heterogeneous system, and that we need to be able to individualize treatment. This is the space of precision medicine is entering psychiatry precisely through neuromodulation. So when we talk about precision neuromodulation or individualized neuromodulation, what do we mean? Well, again, let's go back to our levels of analysis. It's anatomy, physiology, and behavior. So if we are going to individualize treatment, we will individualize them based on anatomy, physiology, and behavior. So the anatomy could be controlling the wear. For example, this MRI-guided TMS that I just showed you earlier. But again, anatomy is very important, but it's not just about the anatomy. We can also individualize based on the physiology. We wouldn't control the where, but we can control the when. So an example of that could be EEG-guided transcranial alternating current stimulation, or TMS, when we are individualizing the frequency stimulation or the timing of the stimulation to coincide with a peak or with a trough, with any specific point of intrinsic oscillatory dynamics in the specific individual brain of that patient. And last but not least, we want to control the what, mental states, behavior. This is an example of combination therapies when we're doing physical therapy and TDCS to improve hemiparesis after stroke, or CBT plus TMS or TDCS to improve clinical outcomes. This can happen in form of traditional therapies, but also in the form of virtual reality-based behavioral interventions that shift the state of the brain in a given direction. And in that specific controlled mental state, we applied a given pattern of brain stimulation. And again, by controlling the where, the when, and the what, that's we can develop precision neuromodulation treatments. And again, what I showed you earlier, specifically for suicide, is a case of really trying to control the where without really controlling the when or the what. So I will end here. I try to give you a specific example of a study and then present the framework, and hopefully this will trigger a discussion afterwards. Thank you very much.
Thank you so much, Joan. Giulio, whenever you're ready.
Thank you very much, Joan, for that very wonderful introduction. I think it has stimulated many ideas in my mind to discuss, so I think we'll have an interesting panel. So I want to tell you in my talk about what we're doing about major depressive disorder with the technology that we have, which is transcranial current stimulation. And I'm going to give you first a brief overview of TDCS, which is this non-invasive technology in which we use a few electrodes and we place them on the scalp, inject currents, which are very weak and tolerable and safe. And from them, we can induce electric fields in the brain. You can see on the left of the slide, the electric field generated by a montage with 4 electrodes targeting a particular area of the brain. And you can see that the scale, it's in volts per meter, which is electric field units. And you see that it has a peak of 0.3. On the right, you can see an analog simulation of using TMS. And as you can see, the electric field is much stronger. The distributions are not too different. An important difference between the two techniques is that TS is applied for long times, like 20 to 30 minutes to an hour. TMS is applied through short pulses, and there is a trade-off actually between the time and intensity of the fields that are induced that are leading to be roughly equivalent if you consider the 2 dimensions. But the mechanism of action of TS is slightly different because we don't induce action potentials with TS, but we can only modulate the probability of firing of neurons in different neuronal populations. These electric fields can actually alter the membrane potential of pyramidal cells and other ones, with the effects of depolarizing or exciting those cells or hyperpolarizing or inhibiting them. And the effect of all this is a modulation of the dynamics of the brain as an oscillatory system, as a dynamical system. And this leads to plastic effects. So the ultimate goal is to apply the electric field for some time and modify brain dynamics, and during that period, induce plasticity in the brain that will have beneficial effects for the patient. So this is the basic idea behind TS. So we started with the early work by Michael Nitsch and others roughly 25 years ago. And the basic way of doing TS back then, and it's still used by others, is what we call TS 1.0, in which large sponges are used. They're positioned using the 1020 system. Targets are typically defined in terms of the 1020 system, and there is no underlying brain model optimization function or optimization method. The next step from this is TS 2.0, in which we started using modeling, computational modeling to simulate the effects of stimulation only at the level of physics. So this technology uses small electrodes. It uses a cortical model. Sometimes the targets are defined in terms of a region of the brain or even a network on the brain, but is specified outside of the process, let's say. And the brain model is simply a physical passive model of current conduction. The optimization function is defined in terms of the electric field that is desired to target the specific areas that are specified. And the optimization method then becomes algorithmic. And this is something that we are starting to use now in a lot of studies, and which can be used in a personalized manner, or it can be used using group data, as I will show you in a second. The last one is TS 3.0, in which we use the same technology in terms of electrodes and the cap and the positioning system, But now the targets are not defined in terms of regions or networks. Instead, the idea is to specify desired outcomes in terms of the physiological dynamics of the brain and associated symptoms. So for example, in epilepsy, we may say, I want to reduce the spread of seizures as a target. And this is what drives the optimization problem. Now, the brain models are no longer only physical, but they include also physiology. As Joan was mentioning before, anatomy, physiology. Well, now we're introducing physiology in the modeling part. And the optimization function, then it's defined algorithmically, but in terms of the functional or plastic change desired in the model. So this is TS 3.0, in which we're working right now. Here's the technology. And I think I have here a picture. I don't know why this is not clicking well, of what we call neurotwins, which include all these physical and physiological models of the patient and the pathology. So with regards to physics, briefly, the pipelines that we use in order to construct these electrical models of the brain start from an MRI, from which we construct biophysical head models using finite element modeling. And this gives us a predicted electric field in terms of what electrodes have been chosen on currents. Okay, let's discuss now about the concrete case of the depression. So as Joan has already mentioned, there are various techniques, including ECT and transcranial magnetic stimulation, that have been used. TDCS was first investigated in the 60s. Nowadays, a typical targeting scheme for MDD is always concerned with the left dorsolateral prefrontal cortex and with cathodes placed in different regions. The goal by TDCS is to elevate neuronal activity in the dorsolateral prefrontal cortex and normally the left one. And this is associated with various findings having to do with hypoactivity of this area, or, for example, connectivity of this area with deeper brain regions that have produced good results with DBS. This is work by Mike Fox and his team. There is a long list of publications now and studies using TDCS, and there's good evidence for efficacy. But now I think the real interesting research is concerned to how to increase efficacy and to really show that this is a clinical relevant solution. Here I give you a list of some of the most relevant recent papers, just to show you. What we have been developing and are using in our studies, in the case of depression, it's a home system study. So it's a system designed to be used in an easy fashion at home by patients, and it's connected to the internet so that it can provide feedback to the clinician or investigator. It can be used to program different types of currents in the brain. And it provides, as I said, this remote access to ensure that the system has been used correctly, that the sessions have been completed as planned, and so on. So this is the technology that we use for a pilot that was completed a couple of years ago in the US, multi-site pilot with 37 subjects that enrolled, and it was open label. It was a completely virtual study, so patients never went to the clinic. The whole thing happened at their homes. This was in COVID times that it was designed. And it consisted of stimulation during many days, consecutive days. So during the acute period, patients self-administered 30-minute stimulation sessions during 28 straight days. And then there was a taper period in which the frequency of stimulation decreased for the next 28 days for a total of 9 more sessions. And the follow-up consisted of a month, basically. And the primary outcome was mean reduction in remotely clinically rated MATTR score, comparing the baseline versus the post-treatment. The summary of this open label study is in the last row. Primary 64% mean reduction in clinically rated MATTR scores at the 4-week post-treatment compared to baseline, and 73% response rate. I want to give you a few more details about how we did this. So with regards to the target, there's work, as I mentioned, that has indicated hypoactivity in the left prefrontal cortex, but also interesting work showing that the efficacy of TMS actually is related to its intrinsic functional connectivity with the subgenual cingulate. And basically, some years ago, we used this perspective to inspire the idea of doing brain stimulation not only on single targets but on network. So if you know that the connectivity to a deep brain region is a predictor of efficacy, why not ask what is the entire connectivity on the cortical surface, which TDCS can address, and can we actually do something about it with a multi-channel distributed network? And okay, this exercise produced the technology that we now use for optimization of the electrode locations. To design the montage for this open label study, we took a slightly different philosophy, which was to say we want to have a simple montage because we don't want people at home to have to self-position 20 electrodes or something like that. And but we did take at heart the idea that the left dorsolateral prefrontal cortex was the target to be addressed. So we came up algorithmically using what we call group optimization, which means that we did simulations using a database of about 50 MRIs, 50 patients. And we came up with a common montage that would give the best fit for all of them. So the target itself was derived from TMS coordinates, and that's how we designed the system. So it's a bit more complicated than the two electrode systems that you may have with sponges, but it's not hard to use, as it turned out, and it gives you this focal effect mostly in the area that we want, and we don't affect areas that may also be involved in depression in an unwanted way. So here's an overview of the protocol with acute phase. The green lines are days of stimulation of these 30-minute stimulation sessions, the taper phase, and the final assessment. And here's a visual rendition of the results, where you see on the left the scores per patient. Each line is a patient. And you have in the baseline and week 4, week 8, and 4-week post-assessment. And in the middle, you can see the MADRS score box plots, again, for the 4 time points. And what I wanted to emphasize here is 2 things. One, that we also have been collaborated with a team in Germany, Michael Nisch's team, in order to do a similar study, but controlled and with 3 arms, in fact. One which was sham TDCS, the other one optimized TDCS, high definition, like I described, and the other one conventional with sponges. And the results indicate, first of all, the blue line that you see on the right plot is very similar to the box plot in the middle. So even the starting point at the baseline, the average scores were similar, and the progression is very similar. What their work has added, which was very important, is to give a sham version of that, which is the gray line, and also the large sponge bipolar classical montage, which sits in the middle of the 2, as you can see. What else? And then there is another result that came out recently by Rachel Woodman and Cynthia Fu's lab, and which they did another bipolar study at home. And basically, their results are quite compatible with the results of Salenijad on the right. So the conventional and sham arms are similar to what they found. So all in all these results seem to be sitting together comfortably and consistently. And the bottom line that I just wanted to give is that I think that these are exciting times in which we're starting to understand really the mechanisms and the etiology of depression, and we have better, more precise technologies to start to probe what the actual optimal treatments are. And in addition, that these technologies can also be taken home. So they are potentially of high clinical relevance. And that's all from my side. Thank you.
Thanks so much, Giulio. Francesca, whenever you're ready.
Okay, great. Thanks a lot, Joan and Giulio, for the stimulating presentations. In this talk, I will focus on computational modeling applications in the context of depression, and hopefully give more room for discussion later. So as Joan and Giulio introduced already, major depressive disorder is incredibly complex, and we know it presents differently across individuals with unique combination of symptoms and biological patterns. So rather than seeing depression as a single disorder, we are starting to see it as a set of distinct neurobiological subtypes, each with its own profile. And this variability makes treatment, of course, challenging. So to address this, we need personalized models that can pinpoint these mechanisms and tailor treatments to the individual. Some individuals, for example, experience disruption in the emotional processing, others in cognitive control. And with tools like NeuroTwin, we are moving towards more tailored therapies, particularly in the use of neurostimulation indeed, and which can be highly targeted. As Giulio was mentioning, the NeuroTwin technology is our answer here to this need for personalized predictive modeling in treatment. So what are these neurotwins? Simply put, they are virtual brain models or twins that allow us to simulate how a patient might respond to different treatments, enabling us to optimize therapy before we even start. The approach in neuroelectrics is different from cellular level or small scale models because we focus more on this whole brain simulation. And this approach combines biophysical and physiological data to represent the brain network, complex networks, and capturing how various regions interact. And by simulating this interaction, we are better able then to tailor treatments, like again, stimulation, and to fit each patient's brain profile. So it's a powerful tool, basically, that allows us to ask what might work best for this particular brain. And now NeuroTwin technology itself is the backbone of this personalized approach. And we start by creating individualized head models representing each brain geometry and also electrical properties using MRI and other neuroimaging data. This step helps us to predict electric fields during stimulation, so we can design the best montage for each individual. Traditionally, clinicians choose targets based on symptoms and broad clinical patterns, but of course, this can lack the precision of a model in the future, especially that understands the underlying mechanisms. So by integrating physiological data into our NeuroTwin model alongside biophysics, we aim somehow to also overcome this limitation. And also multimodal data simulation and advanced computational modeling allow us to capture more realistic neural mechanisms. But to address this disorder effectively, we need a comprehensive also translational strategy. Our interdisciplinary approach combines neuroscience, psychology, and clinical data to understand how experiences, also emotions and cognition are represented in the brain. And interdisciplinary research will bring together, of course, algorithmic, mathematics, system neuroscience, psychology, psychiatry, and clinical perspectives. And the theoretical backbone we start from is algorithmic information theory. And algorithmic information theory treats the brain as an information compressor, organizing vast amounts of data into what we call structured experiences. And in depression, this compression process can fail, so resulting in persistently low emotional value or positive valence. And in Neuroelectrics, we are exploring in this algorithmic information theory framework, not only to uncover the depression underlying mechanisms, but also to offer a unifying perspective of one of the possible ones that can encapsulate multiple disciplines and also simplify the approach to such a complex problem. So by building on this framework, we aim to create a computational framework that goes beyond addressing symptoms and somehow to provide a cohesive way to target the process driving the depression. To unpack this a bit more, in the agent framework, again, we treat the brain as a sophisticated information processing system. And according to this theory, the brain compresses incoming information, organizing it into structured experiences. These structured experiences help guide our emotions, decisions, and also action. When this compression process is disrupted, like we see in depression, the brain struggles to manage or compress negative information, which can lead to persistent low emotional states. And this approach lets us bridge neuroscience and also algorithmic theory, and it can offer new ways somehow to understand the depressive states. So to help visualize how this works, our agent model includes several modules that mirror the brain's key functions. There is the modeling engine, which builds internal representation of the world, including self, and also predicts future events, comparing them with the actual data. The comparator, which assesses the accuracy of these models, and the objective function, which assigns emotional or experiential value to guide actions. These components form a feedback loop that shapes our action also and choices. And in depression, failures in these models, such as the inability to update models accurately or also assess value effectively, may lead to reduced motivation or even feelings of hopelessness. And this framework allows us to pinpoint where things may go wrong, indeed. So in the specific case of depression, we believe that certain failures within this model may explain some hallmark symptoms. For example, again, in depression, the brain's ability to process and update mental models can be compromised, and the comparator may fail to adapt its internal models based on new experiences, and leads to, for example, overconfident or excessively negative interpretations of some situations. And this ongoing error can disrupt the brain's telehomeostasis, so the ability of the brain of maintaining balance, and keeps the individual, for example, stuck in a low valence or negative emotional state. The objective function also can suffer, so impairing the brain's capacity to seek out or recognize rewarding goals, which might explain why patients with depression often feel unmotivated or anhedonic. But connecting also with the slide that Joan showed, relating circuits to the dimension of suicide, for example, by mapping these agent functions onto specific brain circuits and also identifying biotypes, we can create intervention strategies based on each patient's unique neural profile. For instance, we can have disruption in the salience network, which may underlie emotional response issues, while cognitive control network dysfunctions are often related to executive functions problems in MDD. And recent studies have shown that these distinct connectivity patterns, like, for example, hyperactivation in the cognitive control circuits or hypoactivation in the salience network, correspond to different treatment response. And defining these biotypes is crucial, as it helps us match patients to effective and tailored intervention and move more towards a precision medicine model in neuropsychiatry. Finally, all of these components come together in what we can call a neurotwin platform. And this technology is informed by this theoretical framework, again, like the agent model, and which we use to develop computational models. And again, those models are crucial not only for understanding the MDD, depression, but also for designing therapeutic intervention, which can be both pharmacological or brain stimulation based, or even psychotherapy. And that's all from my side. I also want to thank JT for organizing this timely panel, and I'm happy to discuss with you. Thank you.
Thanks, Francesca, and to all the panelists. Fabulous presentation. So now we're going to open up the floor for discussion. And I know some of you may have thoughts and statements for each other's presentations. If you want to, maybe we could start with that.
Yeah, I really like, Francesca, your presentation. And I think, in that framework of biomarker-driven development, I think these computational models offer, to the extent, it's a theoretical model, but it often offers the possibility for empirical testing, right? So if there's some of these specific computational states that you're linked to maladaptive affective states, then the question is, what would be the optimal stimulation strategy or set of parameters that could change it? And question like, can we change that, and can we measure it? And if we do, what happens at the clinical level, behavior level? What happens in terms of affect processing? Is there, is there a framework to approach that from this kind of empirical framework? Do you have a sense of what are the parameters that may actually be shifting from one computational state to another?
Yes, thank you, John. Thank you for your question. So this framework, and especially the biotyping of MDD, is quite a new frontier that has been basically investigated in this last few years. And what I think is really important would be, of course, to get informed by all the other empirical studies that targeted deep brain area, like in the DBS kind of approach, so deep brain stimulation, which investigated the relationship, for example, between subcortex and cortex, and how stimulating basically subcortical area could give us this network behavior on the cortical level, helping also us to understand how to stimulate in that particular context. So I would say that it will be a network approach to start with, which the parameters, for example, in the model could be the connectivity, so the strength of connectivity, and is like mapping first the structural, so which structures to include in our model, which we know that are basically impaired in depression. and from that to understand the first probably starting from a generalized model, so the normative connectomes, for example, that we use, and then to go more towards a personalized brain, basically, approach.
If I can comment on that, actually, because I was thinking about this in the context of Joan's talk. So if we take the case of your study in suicide, Joan, you identified one particular posterior brain region that seemed to be associated as a predictor of response and as a biomarker, right? So one question I had is, at the beginning of your talk, you listed a set of symptoms or dimensions. Were your patients biased to one of those dimensions, or were they all across the board on that?
Right, good question. So I think that's the second layer of analysis that we're currently actively doing. So we're actively doing two things. One is using this data to start looking at this dissection. We're limited because of the sample size, it's 10 patients, right? Yeah. So this was a pilot study to kind of give us a go, no-go decision in terms of thinking, from the biomarker that we observed from the suicide side. Does it make sense to bring it to TMS? And given the results, then we read it as a go, and so we're running the randomized control trial. But with the data that we have, we're starting to look at these dimensions, and so far it looks like it's heterogeneous. But again, I think what we're trying to do is, and there's a broader research enterprise across other projects as well, to see other features that explain biological features, signatures, whether it's physiology or anatomy or behavior, that explain not the overall severity in depression, for example, but the anhedonic dimension or the cognitive control dimension. So there's a strong emphasis in our group to look at neuropsychiatric disorders from this dimensional perspective, get understanding that these are not diseases, these are clinical syndromes, and all clinical syndromes in medicine are heterogeneous. So it's hard to go from a clinical syndrome to biology because, there are going to be many different diseases, right? So but if you go from a clinical syndrome to the dimensions, I think we do have a much better chance of understanding the biological basis of cognitive control, of anhedonia, of sleep, or appetite. So in the case of this specific set of patients, they were quite diverse, but we're still diving into the data.
Because just for this, let's suppose to illustrate the discussion that they were on the self-perception. Self-perception was very affected, no? So with the agent modeling framework, what we try to do is to identify what types, we try to identify the etiology with the model. So is it a problem of the modeling system? Like, is your self-model wrong? And that's what's driving your low valence, for example. And if you were to tell me, yeah, these patients are indeed, they have a very bad low self-perception, this could indicate a disorder of the modeling system that is impacting indirectly the valence, but it's not the valence system itself which is affected. So if you wanted to design a stimulation protocol based on this model, you would then go dive into the circuits associated with the modeling engine and having to do with self-modeling in this case, and study how to best do, now using the physiological models that we discussed before, or with network or a network approach, trying to understand what is the best way to do that. So that's a little bit the philosophy of the agent framework. It's not going to be an answer for every problem, necessarily an easy answer, but at least guided the questioning a little bit, I guess.
I see. So I guess they're linking the models to empirical signals. You could apply the model to different types of signatures. This could be physiology, it could be from EEG, from stereo EEG, from surface EEG, from the DBS electrodes, fMRI connectivity, perfusion, NIRS, like you name it, right? So you could get like different types of inputs and model them within that framework.
Yeah, and in this case, one important element I would say is not only the physiological measurements, but also there's the experiential side, which plays a big role, because suicide is a very peculiar phenomenon in which you have very low valence, presumably, but you also decide to solve that by taking your life, which is kind of a very anti-homeostatic thing to do in a sense. So you can try to think how, just as an exercise, imagine a robot that does that, that you have designed as an agent that has this modeling system, objective function, and planning system. How does a robot decide to self-destruct, and why? Well, one potential answer that we propose, I think, in the paper is the idea of telehomeostasis. So it's like a form of apopsis, that if you think that you are not adding, that your life is miserable and you're not adding anything useful for your kin, you're useless or you're a negative, you're weight on other people, then there might be an internal signal to say, okay, just self-destruct and get out of the way. I mean, this could be a hypothesis you could formulate from an AI perspective, say, on why would that robot do it.
But that alone is not enough, right? Because lots of people who suffer from mood disorders and other conditions may experience those very negative emotions, but not
Exactly.
Translate those into the behaviors of suicide, right? So I think that's why it's helpful to think about something as complex and heterogeneous about suicide from this dimension, because again, this negative valence is just one component of the full set of behavioral and affective and cognitive and autonomic dimensions that go into that final decision of self-harm. And there's probably going to be different biological signatures that characterize those distinct valences, right? And I think it's important to highlight the heterogeneous. We many times in the clinic we think about suicide as an impulsive act, and patients who are impulsive are more likely to commit suicide. There's risk with certain patients with TBI, traumatic brain injury, who become impulsive because we know the risk of suicide. There's been research coming from Matt Knox's lab here at Harvard, who's a suicide research lab, that actually if you test for impulsivity, many patients are not. As a group, actually, there's a study says that actually they're not impulsive. So again, some patients will be impulsive, some will not be impulsive. And that heterogeneity is very complex to model it unless you break it down into, you don't just model suicide, you model these different subunits, right?
Exactly. What potential causes could lead to this? And there are many probably, and with different symptoms, I guess. No, that's I mean,
exactly.
I mean, low valence is common in all cases, I guess. Low valence is part of the problem, but there are other aspects, no? Like you're saying, like self-model may be affected, or
right. But even valence of emotional valence, if that's what you mean. It's like it's in depression. Depression, it's a mood disorder, but it's not just about mood. And when we think about mood, sometimes we think there's kind of this continuum of negative emotions and positive emotions. And now we know that these are actually two different continuums, right? There's a continuum for negative emotion, and that's distinct from a continuum for positive emotions. And we know because there's a different anatomy, there's a different set of circuits that process negative emotions and circuits that process positive emotions. And you can have patients clinically, sometimes when we teach that, the patients are flat but not sad, meaning the patients don't feel sadness, but they're so stuck into the incapacity to feel any reward. And that can be as tormenting as extreme sadness too, right? Sometimes bipolar depression has more of that flat flavor, and unipolar depression is a big generalization, but it's more like the sad component, right? But you have plenty of patients with unipolar depression who are also flat, who have both, right? You can have one, the other, or both. There's going to be an emotional component, it's a mood disorder. But again, there's different subtypes of emotional expressions that go into what we call major depressive disorder.
Yeah. In the agent model, maybe we simplify it too much, but we just call valence the sum of those two. So it's a single entity that takes into account both circuits, let's say. Yeah.
So, but you could model it by dissecting those into building like two different computational units, one for positive, one for negative, right?
Exactly. Yeah. I mean, so one thing is the agent model, which is abstract, but then there is the physiological, neurorealistic modeling, which is what we want to do in order to be able to apply stimulation.
Yeah. And I think at the end of the day, beyond these academic and mathematical and physical models, if you think about what we're trying to do, which is to address a public health problem, the question is, how do you put these frameworks in the service of faster and more effective treatment development strategies, right? So again, I think that because that's what we want, right? And what patient wants, and that's this is kind of the home run, right? So I think if you can start again, we've been in the blind for treatment development. That's why that curve for suicide looks so horrible, because we haven't had a mechanistic model, I would argue, to frame the treatment development efforts, right? And I think I've been thinking more from a kind of anatomical, physiological, biological perspective with the non-invasive tools that we have in humans that are imaging and EEG and physiology. But I think bringing your modeling strategy, that I think as long as you can validate it empirically, that becomes, or potentially can become, a response biomarker. And then the work becomes, how can I optimize my function? So how can I optimize my set of parameters, increasing, decreasing the intensity of stimulation, larger or smaller electrodes, a specific frequency or another frequency, a given montage or another, all of how by changing those parameters, I'm moving the dial in my response framework, in this case, your computational model. And because that's a kind of faster throughput strategy to really test many different parameters. You have to do a large clinical trial for each one of these parameters. It would be too expensive and too long. But that's not a valid strategy. So we need this kind of experimental framework to do it. And you may, I think leveraging those computational models could actually get us to this very pragmatic goal, which is novel treatments for suicide.
Yeah. I mean, our whole goal is to use the models in order to really zero into the right targets that we need to stimulate and to have some mechanistic basis for them based on experimental data and on anatomy, physiology, as opposed to trying a montage because somebody has tried it before and modified it. So that's the philosophy of what we're doing. And the rationale for going back into a higher level abstraction is because I think there is a need for some kind of framework to try to provide scientific framework for the experiential part of neuropsychiatry, which is crucial. And it's for neurology. I mean, in epilepsy, we don't have to do that. We know that we need to simulate what areas are affected and how seizures propagate. But with something which is experiential, like it's a mood disorder, you need to have some framework to define mood. And you know what I mean? So that's a little bit the rationale for going back. But at the end, we have to go back again to circuits and to data, biotypes, and of course, the clinical outcomes are what we really want.
And I think this is also encouraging for the patients themselves because they are always lost in this marasm of therapies that they don't know, starting from also psychotherapy. That is like a continuous trying to understand which is the best therapy that they could do, and they don't know, and they spend many years, which of course doesn't help their status. Actually makes things much worse.
And also with medications. But if you look at the data actually on psychotherapy, the technique doesn't matter. It's actually the rapport. It's actually the rapport with the therapist that actually leads to healing. But with respect to suicide with veterans, actually, we've seen an increase of suicides with veterans. And actually, if you look at the data, veterans that have actually had childhood trauma, a worse prognosis for them. So I would think that this would be a great kind of pilot, I think, to, if anyone kind of listening has connections at the VA, I think to do a trial, I think with veterans, I think would be really advantageous.
The suicide epidemic is generalized, but there's two groups. One, I mentioned children and adolescents. The other group is veterans. Right? There's more people in the military who die by suicide than they die in combat.
If anyone's familiar with the book, The Anxious Generation, that was recently published, it actually talks about this. And they're kind of, what is his name? Jonathan Haidt, I believe, and talks about, he has two factors involved. One is actually overprotective parents that don't, like helicopter parenting, that don't let their children do anything. And the other is actually less, so this overprotective and this underprotection on social media. And where kind of kids, instead of playing outside, are on their phones. And so, we kind of want everything in balance. So, I think, maybe even starting to monitor children's brains, like from grade school and middle school, to get, if we can, come up with biomarkers or even look at brain activity to kind of see where these biomarkers, biotypes develop, because how much of it is innate. So we know by Dr. Andrew Newberg, I don't know if people are familiar with him, he's a neuropsychiatrist at Thomas Jefferson University. He's written a number of books on primarily on kind of spirituality, and talks about how by meditation will actually build the areas of the brain like the anterior cingulate cortex. So if we started doing this in grade school, and I know some school systems have, and even monitoring the brain, can you imagine if, and I know budgets are tight in school systems already, but if we started actually monitoring children's brains, we could catch, these dysfunctions at an earlier age. So And
children's brains are moving targets. So I think there's interventions you can do at that stage that would kind of consolidate processes and biological states that can have long-lasting impact.
Joan, I had a question for you. First of all, the results that you're showing are spectacular. So congratulations. I know it's a pilot study, it's open label and everything, but the correlations you're showing are impressive. And I want to ask you if you have any interpretation for the region that seems to light up.
So it's not so much that it lights up, but it's how connected it is to that. So we either fire together more or less, right? So I mean, we have the specific is the executive control node. So they have the executive control network that has nodes in the frontal and parietal cortices predominantly, in other regions as well. Of that circuit is the node that is in the inferior parietal lobule, so on the right side and the back. And we know that this is kind of the director of the orchestra in the brain, and it's kind of allowing other networks and other functions to coordinately process, all the information that we need, and coordinately process information also to respond to the world. And the anterior cingulate is more of a very complex node that does a lot of integration also of cognitive and affective information. So again, as we're trying to dissect the connections of those two nodes with those different behavioral dimensions, affective dimensions, but I think there's a certain improvement of top-down control of affective states, and that it's probably what's driving some of the kind of benefit in terms of reduce severity of the suicide ideation. It's a testable hypothesis. We have to test it, and we are testing it. But I think we need a bit more data to fully test it. And but so far, what we're seeing is that may be it. But again, there's other dimensions. Those different dimensions are just some of the dimensions. And by the way, we're measuring them all. There's specific psychometric tools to measure positive affect, negative affect, impulsivity, cognitive control, decision making. So we have specific tools for each of those dimensions, so we can fully characterize the suicidal patients at that level of dimensions, and then see how these interventions, via moving the big measures of suicide ideation that we use clinically, how they move the specific dimensions.
Got it.
And Francesca, I was curious about, I love the idea of sort of the biotypes, but in terms of determining, which one, and I'm sure there are others that may exist, is it through an MRI? Because I'm trying to think like in terms of practical application. So if kind of step one is determining the biotype, is this something that an EEG could pick up on, or you would definitely need kind of that spatial resolution to have, an MRI or?
Yeah, thank you, JT. That's a great question. I mean, of course, it always depends on what kind of information you look for. Of course, EEG, for example, have been used to find for biomarkers in MDD, as in many other disorders, especially for the temporal resolution, which means that could capture features like complexity in the brain, for example, so much, the complexity is reduced or the entropy is reduced. So it depends on what kind of biomarkers you look for. Of course, lately, I think the substantial progress in identifying these biotypes was more with imaging in terms of fMRI. So because they help more to define these biotypes by identifying the characteristic patterns in brain networks. So like the salience, the default mode, the cognitive network control network, and this was only identified by fMRI so far. But it's true that, I mean, biotypes are not only connectivity biotypes. We can have many other basically information. So yeah, it's what to say. Biotypes, for example, could be defined by also genetic markers or hormonal profiles or even behavioral patterns, as Joan was saying, measured through cognitive testing. So we have different approaches, of course.
Yeah, the spirit is of data simulation, of multimodal data simulation. So whatever is available, and right now the most precise data that we have and repeatable and collected in large numbers is fMRI, and of course self-reports and cognitive tests are also valuable. But
again,
go ahead, John.
Sorry.
No, it's okay. I was just going to say that this is recent work, especially by the group in Stanford. Williams' lab, I think, has been working a lot on this. But yeah.
But I would say, as helpful as fMRI is, and we do lots of that and to show you some results, I think if you think about scalability, that may not be the most scalable tool, right? So, you think about developing tools that can help us capture biomarkers to inform either clinical decisions or inform specific treatment protocols. molecules like EEG, while the spatial resolution may be not as good, but the temporal resolution and type of information that you can abstract from it is probably richer. And so in that respect, it becomes a very attractive platform to start thinking about biomarkers, biodoping, if you want to do it at scale, because you do need scale.
Absolutely. No, I guess what I was referring more at the research stage. That's what we're using. But once we identify these biotypes and we translate them into circuits, then we can ask what are the EEG markers that should be associated with these functions, and we can dig into this other part. You're absolutely right, Joan, that EEG is if we find good biomarkers in EEG, they will be much more usable and much more relevant also for following up patients at home. This is also something we're working on.
And I think I know it's getting late, so I appreciate everyone's time. Just kind of as a last question, I think just accept psychiatry in general. They're not always receptive. I mean, we have this large divide between neurology and psychiatry, unfortunately. So for typical clinicians accepting this technology, it's challenging because of the way psychiatrists are paid, right? The way they treat patients. So can anyone kind of recommend suggestions and how making the psychiatry industry in general more receptive to, I mean, these much needed advances, but a lot of times change is difficult because people are accustomed to the way things are. So any kind of suggestions on?
I mean, I think this is changing. In the last 10 years, I would say, we used to think that treatments in psychiatry are pharmacology and behavioral therapies, and yes, we had ACT also kind of on the side. And now I think, given the explosion in terms of options that are not just research options, but that are kind of getting through the FDA, being approved, being commercialized, being covered by payers, it's really changed. And the number of private practice and community clinics that are now offering neurotechnology-based treatments, we often call them interventional psychiatry practices, are really growing. In response, we're starting to see new codes that are changing how psychiatrists are being reimbursed for that. This is in the US, of course. In Europe, I think, in other geographic contexts, the specificities of the healthcare systems and the economics of that are also shaping how well these treatments are being incorporated. But I think that is one component. The other component is always education. Right? Most psychiatrists will use what they learn in residency for the rest of their lives. And if they didn't get exposed to this, they can adapt it later. Psychiatrists and cardiologists and neurologists and plastic surgeons. So if they, I think we have to emphasize kind of at least teaching people how to think about it so that, we know one thing is that this field is moving very fast. Every 3 years, we have a discovery that is not just a discovery, but it's a discovery that changes practice, right? In the last 10 years at least. So I think they have to be ready to understand the framework more than just a specific way we do things now, and be able to and know how to adjust it. But I'm very optimistic about it. I mean, you think around, at least in the US, but also in European countries, there's an increase in the development of clinicians adopting these tools because they work, and the evidence at the end of the day will impose itself, right?
That's great. I appreciate your optimism. And so thank you everyone for your thoughts today, and everyone for joining us. Thank you for your time. Hopefully we'll see these changes not too far down the road.
Thank you.
Thank you so much.
Thank you for organizing this, and thanks to all the speakers.
Thank you, everyone.